All right, let's get started. So my name is Vilma and I work for MEDTRONIC. Tonight, I have the pleasure of hosting this webinar where you'll get to hear from Dr. Walsh. Dr. Walsh is both a urologist and a urologic surgeon. Dr. Walsh specializes in a wide range of urologic care with special interest in voiding and pelvic floor dysfunction and how it relates to surgical correction of urinary incontinence. Dr. Walsh is a member of the American Urological Association and is a diplomat of the American Board of Urology. Tonight, Dr. Walsh will be speaking on overactive bladder, urinary retention, and fecal incontinence or stool leakage, as well as a therapy called Interstim that helps to treat those issues. As I mentioned, I work for MEDTRONIC, and that's the company that's developed this therapy. While you may not know the name MEDTRONIC, you probably do know someone who's had a pacemaker, and that's what we're most known for. So without further ado, I'm going to pass the mic to Dr. Walsh so that you can hear more about this. But before I do, just a few reminders. Everyone's phones were muted upon entry. If you have a question, please feel free to type it in the Q&A box at the lower portion of your screen. Please make sure that you send the questions to both Dr. Walsh and myself and not to us privately or separately. All names remain anonymous. We will answer these questions following the presentation. So allow me to welcome Dr. Walsh.
Hey everybody, I'm Buzz Walsh. Thank you for joining us. I appreciate taking some time out of your busy day to be here with us tonight to talk a little bit about overactive bladder and all of the issues that surround that problem. So we have a short slide presentation. I will run through the slides and try to be as quick as possible. And then really, once we've given you all the information, we want to move on to the question and answer session. So away we go. I think that, what I hear on a day-to-day basis in the office is that most people really are embarrassed to talk about their bladder dysfunction. And they go to their primary practice physician's appointments and they talk about their high blood pressure or their diabetes and all the kind of pressing medical issues. And then as a fourth or fifth issue, as the doctor has his hand on the door and is leaving the room, oh, by the way, doctor, I've got some problems with my bladder that I'd like to talk about. And, as you can see on the left-hand side, there's just a number of things that, be it, I know where every bathroom in town is, to this disrupts what I'd like to do on a daily basis because I simply don't trust myself in a situation where I don't know exactly where the bathroom is. So our goal tonight, as you can see, is live without limits. Let's understand exactly what we're talking about and the diagnosis of incontinence. And then I will show you a little bit about the care pathway. And that's how we start from the first office visit with us all the way through to some more advanced therapies if necessary. And we'll talk about those advanced therapies. And specifically towards the end, we'll talk about the advanced therapies that MEDTRONIC is involved with. So let's talk first about how common overactive bladder is. As you can see here, it affects about 1 in 6 adults in the United States. And this is just US data. That's 37 million people in the US alone. And to compare that to diabetes, 30 million, vision issues such as macular degeneration and cataracts and such, it's triple that number. So it's a very common condition. And I think that through the years, what we found is many people have the mentality that this is the problem that my mother had, my grandmother had, and it's just a suffer in silence problem. And that's simply not the case. So I hear day in and day out, what's normal for how I empty my bladder? And the first thing that I say is, if you're going to the bathroom more than 8 times during the day, that's probably too much. And we hear people going every 20 minutes, every hour. every 2 hours, and we kind of try and gauge exactly what your timing is. And in addition to that is how fast do you need to get to the bathroom? And is this an issue where I get the urge that it's time to go and I simply can't get there? And it doesn't matter if I know I'm going to be out today for an extended period of time. I won't drink fluids for hours leading up to that to try and kind of dry out as much as possible. And these issues still exist. So obviously, this is something that we don't want life disruption. This is something that is correctable. So we talk about how does the bladder work in general and what happens when it's time to go to the bathroom. Well, as the bladder fills, the nerve endings sense that fullness, and everyone has a different, I call it a trigger volume. How much can you hold before you get that first sensation of maybe I need to find a bathroom? And the bladder, as it stretches and fills, sends a signal to the brain, to the voiding center in the brain, if you will, that says, okay, it's time to start coordinating what the bladder is going to do to empty and how it's going to kind of generate pressure and squeeze and how that relates to the sphincter muscle and how that's going to relax. So there's a coordinated effort here to empty the bladder. The same goes for the bowel. This is the same nerve, both for the bladder and for the bowels. As the bowel fills and as the rectum starts to fill with fecal material, the next thing that happens is a signal is sent to the brain, and the brain begins to coordinate that function. And if there's not a good signal there, then obviously there's going to be a problem. So incontinence in general is multifactorial. It's typically not one problem. It goes from dietary issues, and the most powerful bladder stimulant in the world is caffeine. And most people are coffee drinkers or like their Diet Cokes or anything that has caffeine in it. And that is a terrible stimulant to the bladder, and that's going to enhance this problem. There are numerous medications and supplements that we all can possibly take that can also stimulate the bladder. Reduced physical mobility, deconditioning due to chronic illness can also increase bladder overactivity. And then pregnancy, especially childbirth. Childbirth is traumatic to the pelvis, no matter how easy it is. There are changes in the pelvic floor that can be permanent. Radiation for any pelvic tumors, such as prostate cancer, cervical cancers, things like that, and pelvic floor injuries. Any sort of trauma that happens to the pelvis is going to create some changes in bladder function. So basically, the three big categories that we want to talk about: number one, stress incontinence; number two, urinary retention, and that does not include men with a large prostate that simply are obstructed and can't empty their bladder, but it's more along the lines of people who have some sort of bladder dysfunction where the bladder simply can't generate that pressure head to empty. And then three, the largest category is overactive bladder, and we'll define all three of those a little bit here shortly. So stress incontinence is coughing, sneezing, laughing, and losing control of the bladder. People complain that when they exercise, they have loss of urine. Arguably, one of the most common referring issues to me for their stress incontinence are young mothers who say, I can't jump on the trampoline with my kids. And I hear that day in and day out. And that ultimately leads to people needing to use a pad or a liner, or in severe cases, a pull-up in order to control bladder issues. Urinary retention is overfilling of the bladder where you may not even have a sense of fullness at all. These issues tend to be somewhat slow and insidious as they occur. And so you don't necessarily have the sensation that I'm starting to hold on to more and more urine. It's simply that you're emptying your bladder less and less. And it can lead to the point where the bladder simply doesn't empty at all, and patients need to catheterize themselves several times a day in order to empty, or have a long-term catheter placed into the bladder. And that could be done through the urethra, that could be done surgically through the lower abdomen, a lot of different ways to address that. And then the large category of overactive bladder. Overactive bladder could be frequency of urination. So if you are going more than 8 times during the day, it could be nighttime emptying, where people can complain of having to get up and go to the bathroom anywhere from 1 to 6 times per night, which leads to very poor sleep cycles and problems with fatigue throughout the day because of those poor sleep cycles. And urgency, where you have to rush to the bathroom. You may know where every bathroom in town is as you're out and about in your travels. And urgency leading to, I simply can't get there fast enough, with urge incontinence. And you're soaking or wetting pads, liners, pull-ups throughout the day due to this problem. Then we talk about the gastrointestinal side of things, fecal incontinence. And that is something that the gastroenterologists have really not wanted to address through the years, because there really hasn't been much in the way of therapy for this problem. And it can go anywhere from the urgency to have to get to the bathroom quickly to empty the bowels, to a point where there's no warning whatsoever and there's some seepage. And people will start to modify their lifestyles dramatically due to that. And that can be terribly problematic. What's the good news? The good news is that unlike what many people thought through the years, we have many, many different therapy options. And traditionally 20 years ago, there was such high dropout in our offices because, frankly, many urologists really and gastroenterologists don't want to deal with the incontinence issues. And so there have been people like myself around the country who embrace this subset of urology patients, and we really have learned to work with multiple therapies. I think that the most important thing is to make sure you have an accurate diagnosis to begin with. And so that's how it starts when you come to the office. You meet with me, or I have one of my mid-level providers, Cara Bresson. She's my teammate. Basically, we work hand in hand to work through this pathway, and we make sure that we're starting out knowing exactly what the problem is and that we're addressing the right diagnosis. And we start with the simplest things possible. We talk about lifestyle changes, dietary changes, anything that we can modify or improve upon that might make the incontinence issues, the overactive bladder issues, better. Then we move on to oral medications. We've had one class of medications that we've used for many, many years. We now have a secondary class of medications that has come online in the last few years, which also can be very beneficial. And then we move on from those. When that's not sufficient, we talk about more advanced therapies. So lifestyle changes can be very simple. As I said, dietary modification. Pelvic floor physical therapy has been something that we have done for many years. We have a few physical therapists here in town who are very good at focusing on pelvic floor physical therapy, which is totally different than what most of the physical therapists do as far as orthopedic rehab. And so you have to find the right physical therapist and understand going in that this is not something that's going to take a month or two to change. This is a long-term commitment towards changing pelvic floor coordination and getting those muscles to behave more appropriately. The classic drugs that we used for overactive bladder, oxybutynin, ditropan, Toviaz, the class of medication is very busy, many drugs, they all behave the same way. And the biggest problem with this class of drugs is there was a very high patient dropout. And as you can see, up to 72% of people in one study drop out within 6 months. And the reason for that is the side effects in this class. There is a significant chance for dry mouth, which can be terribly bothersome. There is a significant incidence of constipation. There can be some blurring of vision. There have been recent studies which suggest the possibility of enhancing dementia in the elderly. And then the newer class of medication, which have come online over the last several years, work in a completely different mechanism. And they don't have those side effects, but in a small subset of patients, there is a high risk for an increase in blood pressure. And so this population of patients who are on these medications, many of them already are struggling with a diagnosis of high blood pressure. And so that's an issue. We have used Botox throughout the body for many years. We've had multiple reasons to use it, from headaches to wrinkles, now to overactive bladder. What we know is that Botox it's a neuromuscular paralytic agent. So it basically stuns or paralyzes muscle temporarily. And that's why your wrinkles go away when you inject it into the forehead, because those muscles can't work. Same thing happens in the bladder. We can inject Botox to calm the bladder muscle down and take away that overactivity. And it can be very effective. But one of the problems is that Botox does not last very long. And so we tend to find that the lifespan of Botox is about 4 to 6 months on average. And so this is a procedure that has to be redone again and again and again. And when it works, it's great. And I inject a lot of Botox and it can be very successful. The other issue, however, is that when it works too well and paralyzes too much muscle, it can cause urinary retention where patients cannot empty their bladder. And then they have to catheterize the bladder themselves 2 or 3 times a day to empty things out. And that can be problematic until the effects of the Botox wears off in the course of 4 to 6 months. And so about half of the patients over time will drop out because they just get fatigued from having to do this procedure again and again. So that leads us to what happens further down the pathway. What are the more advanced therapies? And as you can see, MEDTRONIC has been at the forefront of this for many years as far as controlling the bladder through nerve stimulation. And so let me show you a little bit about that. The first thing is we can go down at the level of your ankle, and I'm going to show you right there at the tip of the arrow is a little acupuncture style needle that we can place into the nerve by the ankle bone. That nerve is called the tibial nerve. And that nerve travels up the back of the leg and enters the pelvis and ultimately becomes the bladder nerve. And so we can do a 30-minute treatment in the office where your foot is up on a pedestal and you're sitting in a chair reading a book. And this painless stimulation can start to retrain that bladder nerve. We typically do it for a course of 12 weeks. So it is a lot of back and forth to the office. And for some patients, that can be an issue with copays, and we recognize that. What the problem that we encounter frequently is that we are trying to stimulate the bladder nerve from 3 feet down the leg. And so there can be some signal loss as that stimulation travels up the leg. And so we find patients do well with weekly stimulation over the course of 12 weeks. But when we get to the graduation point, we finish with 12 weeks and we kind of say, what happens now? We typically transition to a once a month stimulation to try and kind of remind the bladder, if you will. But what we find is that a subset of patients over time start to slide right back to where they began. Some patients do well and never turn back and are great and bladder has been retrained, and other patients fall somewhere in between the two. And so it's a great option, but we do have some concerns about the longevity of the success. Sacral nerve stimulation is something that is a much more direct stimulation of the bladder nerve. And this is something that we can do in the office as a simple test to find out how well it can work. And the way that procedure works is it's about a 15-minute appointment where you're laying down on your tummy, and I can go right over the sacral bone at the base of your spine, and just based off a little landmarks that I can make measurements from, I can inject a little numbing medicine into the skin, and that stings, and that's arguably by far the worst part of the procedure. But then I can take that same little needle and I can move that needle around until I find the bladder nerve, and then we can directly stimulate the bladder nerve. And with a direct stimulation, without losing any of that signal coming up the leg, what happens is we create a pelvic floor muscle contraction. And with that contraction, as I'm doing the stimulation, I typically ask the patient, what do you feel and where do you feel it? And patients typically describe that contraction as a fluttery or a tapping sensation. And if they feel that in the area of the bladder or at the base of the pelvis, then with success, we're exactly where we need to be. If the sensations felt in the rectal area or in the cheek of the buttock or radiating down the leg, then that's not the proper nerve, and we move on until we find the proper nerve. If we do get that correct stimulation, which I would fully expect to do, we can then leave a little electrical lead next to the nerve, and that's taped down to the skin for 3 days. And during those 3 days, you have a little programming device that almost looks like a cell phone, and that device is constantly stimulating that nerve. And this is both for bowel and for bladder overactivity. And while it's doing that stimulation for 3 days, we have you keep track with a little diary as to what exactly is going on. And if you say during those 3 days, gosh, I was dry, or I didn't have to hurry to the bathroom, I had much better control over my bladder or bowel function, and I was much more satisfied, then that's an indication that we should have a further conversation about permanent implantation. And the permanent implantation is a small device that's implanted into the buttocks. And we have two options as far as the batteries go. This is the more standard battery, which, as you can see, is quite thin, rather small. We bury it deep in the buttocks, so it's really not sightly in any way. And that can last for about 10 years. And it's hands-free. It doesn't require any reprogramming typically, and certainly not any recharging. We also have a smaller implantable battery, which can last anywhere from 5 to 10 years, and it is rechargeable. And so every 1 to 2 weeks, it requires a simple recharge. And people often choose that if they want the smallest implant possible. But that is something that we simply do the test to see how well this is going to work. The test does not commit you to any sort of implant. And so this is the beauty over the last 6 years, once the FDA approved us for doing the test in the office, it saves us a trip to surgery simply to put a test in to find out how well it works. So this is a much, much better system of finding out how well sacral nerve stimulation might work for you. So in trying to decide, do I want to do this? Is this the right option for me? I tell all of our patients, overactive bladder, fecal incontinence, these are not medically harmful issues, but they can be incredibly bothersome issues. And so you are the only person who truly knows how bothered you are and whether it's time to take that next step. And that next step begins with an appointment in our office simply to talk about your issues and make sure that we're talking about the proper diagnosis. But it can lead all the way down the care pathway towards this neuromodulation, which may arguably be life-changing in some cases. Is it safe and effective? People want to know what the side effects are. There really is no side effect or potential complication with implantation other than any sort of device failure. And honestly, I've been doing this for just over 28 years, and I've not seen a device malfunction. All I have seen is the battery does die at some point in time, and it does need to be changed. And so as you can see here on the screen, the success rate that, as far as satisfaction, and that's really what this is, goal-oriented therapy. What are we trying to do? We're trying to make patients more satisfied so that they have more freedom over their bladder and their bowel dysfunction. And so 76% achieve success. And if you look at all the other therapies, it's not nearly close to that. This says it all right here. People can get back to doing whatever they please without having to worry about where a bathroom is, what they might be doing where they'd be caught short and have any incontinent episodes, or change a pad, or do anything that's disruptive to their normal lifestyle. That takes us to the question and answer period. I'm happy to stay here as long as you have questions. I'm going to turn it back over to Velma so we can address those questions in order. Thanks so much for listening.
Well, that was wonderful, Dr. Walsh. I did get a couple of questions. So our first question is from a patient that says, I have neuropathy, both LFN and SFN. I am concerned that this neurological disorder is largely responsible for my OAB issues. Will this therapy help this despite the neuropathy?
I think with neuropathies, especially lower extremity neuropathies, the tibial nerve stimulation, where we do the stimulation at the ankle, that can be problematic because of the neuropathy. But the direct stimulation of the bladder nerve at the level of the sacrum really works around the neuropathy. And so, yes, I wouldn't see that as a complicating factor at all as far as moving forward with a trial. And what you have to remember is it's a simple test to do in the office, and we try it. And if it doesn't work, we move on to other topics. But if it does work, it's an awfully simple thing to do.
Okay, our next question is, will this help for those that have had a radical prostatectomy?
Yes, I have a large percentage of patients who are men who have had radiation for their prostate cancer or have had radical prostatectomy. Sometimes that incontinence can be stress incontinence, and sometimes it can be overactive bladder and urge incontinence. And it all boils down to making sure that you have the proper diagnosis. And so we would work diligently to make sure we have the right diagnosis before we talk about any nerve stimulation.
I have another one here that's asking if, does a pessary help with this?
A pessary is best used in women who have a drop in their bladder or in the uterus, which is causing prolapse. And the pessary puts everything back into position. Pessaries most frequently help with stress incontinence more so than with urge incontinence.
Another one wants to know if the implant will interfere with MRIs.
No, that's a great question. We are at a wonderful crossroads as of about a year and a half ago. We have moved on from the technological standpoint to components that are implantable, which do not cause any problems with MRIs. That was a huge hurdle for us for many, many years, but now MRI is completely allowable, not a problem.
Our next question wants to know, would this help with Crohn's disease by chance?
Probably not. The root problem of Crohn's disease is not really overactivity at the level of the rectum. It's higher up in the gastrointestinal tract, and so probably not the right treatment for Crohn's.
I am contemplating a spinal cord stimulator for low back pain and peripheral neuropathy. Does that rule out this procedure for me?
No, absolutely not. We have many patients who have both spinal implants and sacral nerve implants. The spinal cord stimulator is typically implanted much higher, so that's several levels of the spine above where I'm working. So the two are not exclusive of each other.
Is this procedure covered by insurance or Medicare?
Yes, it is. We work diligently to make sure that we have all prior authorizations in our office taken care of before we move forward with any steps of this procedure, simply because we don't want any financial surprises to our patients. And so typically all the insurers, other than Medicaid, do cover this as they will cover it if we document everything appropriately. And so we do quite a few of these cases a year. We're very good at making documentation clear to the insurers.
Okay, I have another one. How can one control bowel movement frequency, meaning 2 to 5 times a day, which occurs mostly in the morning and early afternoon? This is problematic when traveling and needing to attend activities. Even after voiding, there is a sensation that voiding is incomplete.
I think that with all of our patients, the most important thing to do is to manage expectations and make sure that we talk about the correct outcomes and what you should expect. As far as bowel frequency, this will not change much. we're really talking about fecal incontinence where there's no warning leakage. That's really what this is approved for from the fecal side.
There are clients with bladder problems due to prostate problems. Would this therapy work?
Again, I think we addressed that earlier. With prostate issues, if there is an obstructive issue with the prostate, then no, this is not the proper therapy. If there is overactive bladder and incontinence issues following any sort of therapy for prostate, either prostate enlargement or prostate cancer, where there's been surgery done and there's no obstruction at the level of the prostate, or the prostate is no longer there, then yes, this might be a great option.
What is the recovery like after getting an implant?
When we do the actual implant, it's a small incision on the buttocks. It's typically about a 2 to 3 inch incision to bury the generator or the battery that drives the system. Again, that's primarily this or our smaller generator. As far as restrictions, the only restrictions I have is I don't want anybody submerged in water. So no swimming pool, no hot tub, no bathtub for 2 weeks. You can get in the shower the following day. And then we ask that you not do a lot of bending over from the waist for the first week or so, just because we don't really want to stress that small incision until it's healed.
We have a lot of great questions here. Here's another one. Is the stimulator adjustable or programmable?
Yes, it is highly programmable. And I warn everyone that some people do very well with the initial programming in recovery before they even leave the hospital or the surgery center after their implant. And some people need multiple adjustments. That's the beauty of this system. It is highly programmable, and we can make many, many little tweaks and adjustments to get it working just correctly.
How do I get my Interstim implant?
The first step is to contact our office to make an initial appointment. We can sit down and talk about symptoms, diagnosis, and kind of get on the care pathway as to what you may have already tried or need to kind of start with and move down this whole care pathway that we have.
I have another one here that's really a great question. And this person had the testing done in another state and then moved to this state. Do they have to start the process over again at your office? Or if there's documentation, can they go straight to implant?
Absolutely. We don't need to reinvent the wheel. If there's testing that has been done, as long as I can access records and kind of review all of that, there's no reason to pick right up where you left off.
Well, and I think that's just everybody's questions that I can see here. So I really want to thank everybody for attending. And if there's any questions, please don't hesitate to contact the office, and they will get you an appointment and answer any further questions.
Thanks, everyone. I appreciate your time and look forward to meeting with you.
Have a great night.